As far as another diaphyseal tumor is concerned, which is multiple myeloma, everything you are already aware of multiple myeloma except for this clinical triad, which we were hoping that one day they are going to ask this question, and they've asked this question in 2021 examination, that the very important key clinical triad related to the multiple myeloma is elderly patient, because this is a tumor of elderly more than 60 years of age, low backache because the lumbar vertebrae are the most common site to be affected by this plasma cell tumor, and hypercalcemia. If there is a presence of raised calcium ionic concentration in the blood, this triad is considered to be multiple myeloma until proved otherwise. All right. So elderly patient, low backache and hypercalcemia is considered to be a very important key clinical triad for multiple myeloma. Rest of the things which you are already aware of, like clinical features in case of a plasma cell tumor, they are going to be the bone pain, there will be weakness, there will be fatigue, there will be anemia, there will be thrombocytopenia, because it is a plasma cell tumor which is decreasing the count of the reticulocytes as well as thrombocytes. So these are the clinical features. As far as other conditions, like there will be spikes on serum electrophoresis are concerned, the immunohistochemistry, X-ray findings are concerned, all these things are getting lesser and lesser relevant as far as clinical today's examinations are concerned. It is a clinical triad which you have to focus on, and the clinical features which you have to focus on in order to mark the correct answers related to this particular diagnosis, that is multiple myeloma. We are going to have a discussion on the X-rays again. Next is osteoid osteoma, next tumor. Now in this osteoid osteoma, there are 2 to 3 important features which you have to remember. Feature number 1, that the tumor is extremely painful, more painful at night, but this pain responds dramatically on the intake of aspirin or any other non-steroidal anti-inflammatory drug. The reason is that, the lesion, it contains the cyclooxygenase and the prostaglandins. The pain which is more at night, but it is relieved on taking aspirin, because the lesion of the osteoid osteoma, it contains cyclooxygenase and prostaglandins. And if you give cyclooxygenase inhibitor to the patient, there will be a dramatic relief in the pain. This is one such clinical feature which will be always kept in your examination if the question is asked in pertinence to osteoid osteoma. Point number 2, X-rays are diagnostic. Already we have talked about that there will be a small radiolucent nidus within the cortical confines of the long bones. If you see this kind of an X-ray, then it is diagnostic just by the X-ray. No other tumor you can make the diagnosis on the X-rays. They are just suggestive of. In this case, osteoid osteoma is a sure diagnosis which you can make just by looking at the X-rays itself. Now, it is one such benign tumor which doesn't go malignant. Even osteochondroma can turn into a malignancy, enchondroma, osteochondroma, the chondroblastoma, we have seen it with the enchondromas, means all the other GCT we have seen it with. So all the other malignant tumor or majority of the malignant tumor can be converted into a malignancy, but this osteoid osteoma, not even a single incidence has been recorded where it has been converted into a malignancy. Radiofrequent thermal ablation, the treatment, because treatment is being changed recently, so they can ask this management. The treatment today is the radiofrequent thermal ablation. That means you put a probe on the skin and you focus the cauterization and thermal ablation is performed. But this radiofrequent thermal ablation is a contraindication. It is a contraindication for osteoid osteoma which is located at these 2 lesions. 1, fingers. Thermal ablation of the finger might lead to a permanent disability because of the disarrangement of the pulleys and the tendons attached. That is point number 1. Second, vertebrae. If it is located in a vertebrae, then the possibility of a heat-related injury to the spinal cord can also happen. So it is a contraindication. Radiothermal ablation is a contraindication in these 2 locations. Otherwise, today it is managed by thermal ablation and not by excision of the tumor. Alright, osteoid osteoma. So every time you will get a question related to osteoid osteoma, they will give you this clinical picture where the patient is having pain, which is relieved on taking aspirin. Alright, whenever you see this term, higher is the possibility that the examiner is asking about osteoid osteoma. Next is adamantinoma. Now, these are the 2 lines which you have to remember about adamantinoma. Point number 1, that it is histologically similar to ameloblastoma. Ameloblastoma, already you are aware of the fact that ameloblastoma is a tumor of the mandible against the second molar. All right. So this ameloblastoma which is happening in the mandible, if the same tumor happens in case of tibia, that is, so it will be called not by ameloblastoma but by adamantinoma. Both the tumors are same, just on the basis of their location they are termed differently. Point number 2, what is the histology then? It is the lining epithelial cell tumor. It is the lining epithelial cell tumor. Simple. All right. So ameloblastoma, adamantinoma, both of them are one and the same thing, but if the tumor is involving the mandible, it will be called as ameloblastoma. If the same tumor is involving a long bone, it will be called as adamantinoma. And the thing that we have already talked about, that 85%, the most common bone to be affected by adamantinoma is the tibia. In 85% of the cases, the large bone to be affected by this tumor is the tibia. So this is what you have to remember about this tumor. And finally is the fibrous dysplasia. You know, fibrous dysplasia is something which is divided into two types. One is monoostotic. As the name indicates, monoostotic means a single bone involvement. And we have already talked about that femur is the most common bone to be affected by monoostotic fibrous dysplasia. And the second one is polyostotic. Poly means where there are multiple involvement of the bone. And the craniofacial bone are the most common bones to be affected by polyostotic fibrous dysplasia. But you know, this fibrous dysplasia is important because of its association with two syndromes. There are two syndromes which are found to be associated with this fibrous dysplasia of polyostotic type. One is McCune-Albright syndrome and the other one is Maza-Brod syndrome. Although no question has been asked related to Maza-Brod syndrome till today, but this McCune-Albright syndrome is something which is very, very commonly and very, very frequently asked. So what is McCune-Albright syndrome, or what are the three components under the heading of McCune-Albright syndrome? Point number 1, it is polyostotic fibrous dysplasia, because this is the condition under heading of which we are talking about this McCune-Albright syndrome. Second is precocious puberty. That means earlier appearance of a secondary sexual characteristics, that too in case of females, is precocious puberty. And the third one is cafe-au-lait spot. And you know, cafe-au-lait spots more commonly are identified in two conditions. One is neurofibromatosis type 1 and the second one is McCune-Albright syndrome. Now in McCune-Albright syndrome, these cafe-au-lait spots are having irregular borders. That is the only difference. While in case of neurofibromatosis type 1, these cafe-au-lait spot or the coffee colored spots spreaded over the trunk, abdomen and axilla are having a regular borders. Now, as far as Maza-Brod syndrome is concerned, which is a syndrome associated with two conditions. One is polyostotic fibrous dysplasia and the second one is soft tissue myxomas. All right. So this is the importance of having a discussion of this fibrous dysplasia tumor. Rest of the things like the location of the tumor, the X-ray findings associated with this particular tumor, we have already talked about this. Next comes the very important tumor, that is chordoma. You know, chordoma is a kind of a tumor which is origin of this tumor is related to the notochord remnants. Now, previously, this tumor was considered to be a benign, but now it is found that it is a malignant kind of the tumor, although of low grade severity, but it is a malignant tumor. Now, there is the involvement of, you know, this is the kind of the tumor in which only the axial skeleton or the central skeleton is involved. Only the central skeleton involvement. And the most common bone to be affected by this chordoma is sacrum. Sacrum is said to be the most common bone found to be affected by this chordoma. And point number 4, one of the very important histological finding associated with this tumor is the presence of the physalliferous cells. You know, this is a one-liner which they have asked once, that physalliferous cells or physalliferous cell appearance is the feature of. Answer for that question is chordoma. So this is, at least you have to remember about the chordomatous lesions. Now, as far as the discussion of the X-rays of the tumor is concerned, it is something that we are going to have a discussion on. But this is something which you have to remember very importantly, that how individually we have talked about the tumor. First of all, if we have a discussion of the tumor, what all we have talked about, then first of all we have discussed about the um, classification. Then after having a discussion of the classification, which were categorizing the bone tumors into malignant and benign, we had the discussion of an important table, that which one of the following are epiphyseal, metaphyseal and diaphyseal tumor. After having a discussion of the location of the tumor, the most common bones to be affected by that particular tumor. Then after this were the X-ray findings we have talked about. Then the radio-resistant tumor related questions are very important. Then the most common tumor overall, age predilection, which will help you in ruling out the diagnosis. And then finally the individual tumor. There are some of the facts which were important for you to remember individually for that particular tumor. Now, having this much in your background, it will be much easier for you to mark the correct answer related to the X-ray findings of this particular tumor.